and now I'd like to introduce Sandra Iuliano. Sandra is a senior research fellow in the Department of Medicine at the University of Melbourne, and she's worked in aged care for quite a while, I think. And she's been particularly researching food-based, so from foot to food, so just one difference, to improving health outcomes in residents. And Sandra has done some really, we don't see a lot of research changing anymore. The evidence base is actually staying pretty solid, but Sandra has managed to make a real change, and that was added to the guidelines in relation to dietary recommendations. And she has also presented this evidence at the Royal Commission in Aged Care, and she's a member of the National Aged Care Advisory Council as well, and a strong advocate for nutritional care and quality of life through improved food provision in aged care. So join me in welcoming Sandra to give her talk on food.
Thank you very much for that lovely introduction, and I tried hard to bring some good weather up north. It sort of stopped raining when we arrived, so I think we've done okay. So this is, I suppose, why aged care. There's two reasons why aged care. One is that food provision is very poor, and we've documented that for a long time. And the second part is that these people are at the highest falls risk than any other group in the community. So when I present data, I'm here presenting it, but I just need to sort of acknowledge there's a huge team of people that were behind this trial, and also a huge team of funders as well. We had to scrounge, is the only word I can say, to get money from all over the world to run this trial. So, I have to thank those people and thank those funders as well. So as I mentioned, with aged care, we know falls rates are way higher, about 5 times higher than if I have similarly aged people in the community. Often they go to care because they fall and they've had a fall. So we've got this collective group that is really at high risk. Falls are one thing, but it's the outcome of those falls. And 1 in 10 go to hospital because of a fall-related injury each year. I always go, when you visualise, I visualise the home, and I visualise the 50 residents, and I know 5 of them are off to hospital that year. In our trial, just to give you some perspective, we had 60 aged care homes, and we observed 23,000 falls over 2 years. So that's about an average of 3 per person, so falls are quite pronounced. Worse still is fractures. Now, we know when there's a hip fracture, often that person, we know within 6 months they've actually passed away, and it's a really horrible way for people to end their lives. Each day, 35 people go to hospital with a hip fracture, and I know from the work we did at the Austin, the data that we showed that the number of people that came from aged care is similar around the world in terms of hip fractures. They cost a lot of money, a hip fracture, and I say that because if we're to make change, often back to your cost effectiveness, you've got to talk money, you've got to talk how much can I save you if we make changes. And that's unfortunately the way that we potentially get changes happening. So, we have 6% of the population over 65 years of age in Australia in aged care, yet they contribute 30% to the hip fracture burden. So we've got this very small group that is costing a lot of money in terms of hip fracture. So what we needed to do is go, how can we prevent these fractures? But whatever we do, it needs to be something that everyone can access. It has to be inexpensive, because if it's really expensive, it can't be done. It has to be safe and cost-saving. If we're going to get aged care providers to adopt this, then it has to be cost-saving to them. Because the first question I get asked is, how much is this going to cost me? And I'll show you how much it costs in a moment. So when we look at protein from food, and I come back to food all the time, I'm not talking supplements, I'm going to talk food. Because I think we often talk about supplements and nutrients, but residents eat food. So let's come back to food. So when we look at the dietary guidelines, we know how many servings we want from the meat food group and also from the dairy food group. So this is what's recommended. But this is what we see in residential aged care. So over the years, it's got worse. They used to have 2 servings of meat a day because they love their meat and 3 veg, but now we're seeing it's coming down to 1. So on average, residents are getting 1 serve of meat or food from the meat food group and 1 serving from the dairy food group. So when you look at recommendation, half, but a quarter of what they should be receiving in terms of the dairy food group. The reason I focused on this food group is that it was a fracture-based study and we're looking at protein as well as calcium from food sources. So why aged care? So one, we know most of the fractures are coming, or hip fractures are coming from aged care. We know their falls rates are high. We know that there are high rates of malnutrition. About 68% of residents are malnourished or at risk of malnutrition. And that's data that we gave at the Royal Commission, that evidence, because it's a risk factor for falls. Their protein intake is inadequate. And we know their calcium intake is inadequate. And also, back to food, their number of dairy serves wasn't meeting recommended. So what they should be having is around 1,300 milligrams of calcium per day, and they're getting around 600, so half, and we want them at 1 or above grams of protein per kilogram body weight, just to give you an idea. So we're not pumping them with protein. People get this notion that, you've got to have lots of, protein. We're just getting them to recommended. So then I asked that question. I think it comes across as a very simple question. Oh, look, if I fed them better, can I reduce falls and fractures? And even when people said, oh, can you do this trial? Yeah, we can do this trial. In hindsight, I don't know what I was thinking, but in reality, I'm glad I went through it because of what we've achieved out of this. So the trial consisted of 60 residential aged care homes in Melbourne and regional Victoria. We randomised per facility for ease, so we clustered the facility. They were randomised to provide more dairy on their menu or continue with their regular menu. We followed all the residents for 2 years, so this is a big, long trial. And then we took a subset of residents and we did more extensive testing. So we can go, if we see a change, what are the mechanisms behind those changes? So now you know why they had that big team of researchers on this. So we went through the food service. One of the key things is that all residents are different, all facilities are different, all chefs are different. So we don't have a manual that we could give them. We said, what do your residents like to eat? What's your kitchen facility like? What are your skills like? And then we made changes according to those 3 things. Simple things as adding dairy to snacks or meals, fortifying milk, that's probably the cheapest way of doing it. Substituting, they often use gravy to lubricate food, use a cheese or white-based sauce. And we modified recipes so that we can improve the dairy, but the calcium and protein intake. So these are the demographics. The key feature I'm going to highlight is this. They were vitamin D replete. Okay, I think without that vitamin D sufficiency, we may not have seen a difference. So previously, 30% of residents were supplemented, now about 70%. So it's a lot more routine. So we take vitamin D out of the picture in terms of being a problem, which is associated, vitamin D deficiency, with falls risk. So I just highlighted that one for you. So this is the data. Now I'm bringing out the food data first because when we do trials with food or with supplements, you often see compliance just disappear over time. So what I want to show here is that they went from about 2 servings a day. The blue is our control and this is our intervention. We got them up to about 3.5 servings a day and it was maintained for the 2 years. The benefit only comes from maintaining that intake. If they took it and compliance dropped off, usually efficacy comes off with it. So this is calcium and we got them up to the estimated average requirement, over 1,100 milligrams, which is great. 72 grams of protein per day, 1.1 gram. The key feature is we didn't change energy intake. We substituted poor quality food, just so that you know, they have about 6 discretionary servings a day, cakes, biscuits, etc. And we substituted that poor quality food for the dairy-based foods. And I just have to laugh at this one. I was asked, "Oh, but won't you give them a heart attack if you give them all the fat from the dairy?" Their intake of fat is over 30% of their energy, and a lot of it is coming from these discretionary foods. So in actual fact, we've probably provided better quality. So what we achieved with this. So I'm just going to walk you through this. This is all fractures. This is the cumulative probability of an event. My blue is my control, my yellow or orange is my intervention. So every time a fracture occurs, the line goes up. The steeper the line, the more fractures. And what we observed was a 33% reduction in fractures across that cohort. And more specifically, and this is probably what was a 46% reduction in hip fractures, which we know are the most catastrophic. And we have data from that smaller subgroup to support what we saw, because you always wonder why did we see this result? We've always got to question our own research, and so we do have data to support what we saw. I think my batteries are going. So one of the key things is we saw, and again I'm going to point you through this, this is no change. Our blue is our intervention, our control, and we saw about a 2% loss of bone, which is what we'd expect in this age group of people. But what we observed was maintenance of bone density. We did it also at the femoral neck. We saw this as well. So we saw this maintenance of bone density compared to loss as we expect in the controls. So I always equate it. I like to see things. I reckon this battery is going. I don't think it was you, I think it's the battery. So one of the key things, you've got to look at the structure of the bone, and what we observed was that cortical porosity also continued to increase. So what we hopefully are seeing is that in our dairy supplemented group, we saw that the thickness of the bone was pretty much maintained, compared to in our control group. We get more pores, so there's more holes dug in the bone, and it tends to thin. A thinner bone is a more fragile bone, so if they do fall, they're more likely to fracture. I think time for a new battery. The key thing we observed was a reduction in falls, and again, you can see intervention versus control. We saw an 11% reduction, thank you, in falls. Now remember, there were 23,000 falls, so it actually comes out to a substantial reduction. No change in mortality, so in answer to the question of the cardiovascular risk, no risk. We also have the cardiovascular data, which showed nothing happened. So in terms of weight, what we observed was this slow creep off of weight. In aged care, when there's large substantial weight loss, it's flagged straight away, and they usually pop them on a supplement, versus what we saw was this weight creep. But interestingly, the weight that was coming off, so about 2%, was coming off from both lean mass at the arms and legs, as well as fat mass. Arms and legs is mobility and function. When we looked at their nutritional status, we observed that it was maintained. So again, this is our group here that maintained mini nutrition assessment score, but we saw a loss of 1 point across the controls. And also, if anyone's used the mini nutrition assessment tool, it clusters them into you're either malnourished, at risk, or you're well nourished. And if I can just show you here, intervention pretty much stayed in their categories, whereas in the controls, we can see baseline to 12 months, fewer people normally nourished, more people going into higher risk groups. We also saw an increase in IGF-1. So again, we're not just talking a nutrient, we're not talking calcium, we're talking the whole thing. And now we can start to see that perhaps with the increase in IGF-1, we've got this capacity to potentially have an effect on muscle as well. So I've highlighted this because malnutrition is a risk factor for falls. So if our control group are becoming more malnourished, their risk is increasing compared to our intervention group where we maintained. So what we're doing is actually slowing the loss. We're slowing the risk as people age. Cost effectiveness, this is critical. So we did a cost effectiveness analysis. Just to give you an idea of the types and numbers of fractures, and as I mentioned before, the greatest number of fractures are hip fractures, intervention control. So 42% of all the fractures are from the hip. So they are the most catastrophic of all, both in terms of quality of life, mortality and care costs as well. So what we do is we looked at a fracture, so we looked at the cost of the fracture from the aged care perspective, also from the rehabilitation and the hospital. So if someone unfortunately had 2 fractures, if their second fracture was more expensive, we started that process again and counted the cost of that second fracture, and then the small duration of the first. So generally, fractures cost more in women than men, and generally they cost more for the older adults than the younger adults, and that's usually because of more time spent in hospital. And here is the take-home data. So intervention cost, it cost us on average 66 cents a day per person, so not a lot of money. So when we look at this table, there's our intervention cost for our group. This is the mean cost for ambulance and hospital and rehab compared to the cost in the control group, so it's a saving of $408. Same with the residential care. So when we look at the total cost, we saw it's a change or a reduction of about $175. So that equates to, if you take the whole program and I look at the cost of the intervention relative to the control, which is just normal care, we saw it's about over $8,000 per fracture averted. So it was cost effective. First thing I did, gave it to government, because that is the way we're going to get changes happening. So just to show, it was cost effective up to $1.07 a day, so it can almost nearly double what we spent and still be cost saving. And it saved the government over $67 million per year. Now, all I did was improve the food, nothing else. So with that, improving the food quality, and all we did use was foods that they can regularly get, and they weren't specialised, they weren't formulated, just milk, yoghurt, cheese you can buy at a supermarket. By correcting their inadequate intakes of calcium and protein, we were able to reduce falls and cost effectively reduce fractures. So this is an approach that I'm trying to push to have as normal care in aged care, because we can show the reduction in fractures. I'm also doing a cost effectiveness for the falls, because if you look at hospital costs, the state costs, falls are federal costs. So if I want to talk to the federal government, I have to talk about the cost to them. So that's coming, and hopefully I can present that next time. So with that, thank you very much, and happy to take questions if there's time.
Thank you, Sandra. Are there any questions in the room for Sandra? Like, it sounds like it's a real no-brainer, doesn't it?
It's not brain surgery.
No.
Without taking away from the work, it's not.
Rick?
Just a quick question. In implementing these changes in residential aged care, what were the challenges, or what were the easy wins for everyone out there wanting to do this? Because it looks super easy, but I'm sure it's not.
Yeah, the easiest win is when you have chefs and cooks that go, wow, I can do this. Whereas you have some that don't have that same motivation. We're currently designed a training program for chefs and cooks, and so that basically to get it out there to everyone, they can access the training so that they can actually do the changes themselves. So motivation in the kitchen, I think, is the critical one.
Last question from Lorraine. Yeah.
Sorry, hi. I was just curious, as well as the reduction of fractures, did you notice any, reduction in things like pressure injuries, or, any effects in chronic wounds in terms of your nutritional change?
Yeah, look, thank you. The only reason is we only had limited resources, and as you know, with pressure injuries, they're quite particular how you do it. But anecdotally, less people using supplements. People are saying pretty much we're not using them anymore. And interestingly, I distinctly remember this, their hair's growing and their fingernails are strong. So for us women, that's really, got nails, it's very important. But what I'm getting at is their health was improving.
Was there a question there, or it's?
I think someone else answered.
Okay.
It was answered in the last question.
Well, we will move on to the next.
Sure. Thank you.
Thank you.
Thank you very much.